5 minutes, go ahead.
So my name is Marnie Moody. I'm a public health nurse who has served the city for 23 years. Thank you very much for allowing me to speak today. I'm also deputing today to address how compensation for public health nurses needs to be top priority in the budget. Specifically, I will speak to the significant wage disparity we face, ongoing understaffing, and how these issues are directly impacting retention, recruitment, staff well-being, and ultimately the quality of care and services we are able to provide our clients. Throughout my career, I've worked within the communicable disease programs, including the sexual health clinics. My current role is in case management, where I ensure clients are aware of their communicable diseases, ensure they receive appropriate treatment, contacts are notified in treatment, and we link them with community services. This includes supporting newcomers who have challenges navigating our healthcare system and clients with substance dependency challenges that need additional support obtaining and maintaining care. Overarching goal of our program is to reduce and prevent the spread of infections. So, staffing levels have not kept pace with Toronto's public population growth over the past 25 years. Our current ratio is 1 PHN to 7,300 residents, whereas Halton and York are 1 PHN to approximately 5,500 residents. Due to insufficient staffing, many reportable diseases receive minimal or delayed follow-up, some none. And in clinical settings, PHNs are often forced to focus on one concern, limiting our ability to deliver holistic, client-centered care. I want to be clear, this is not a criticism of our managers. I personally have a very supportive manager, and I believe most managers are doing their best under difficult circumstances with limited employee resources. Many have taken steps to streamline processes in order to still meet public health mandates while also trying to reduce staff burnout. Nonetheless, the workload remains overwhelming for many, and staff burnout continues to be a serious concern. As nurses, we are committed to supporting our clients and do not turn them away when they are in need. However, clients' needs are becoming increasingly complex, requiring more time and support. We know we are providing care that is below our standards, and this is deeply distressing to us. In addition to our regular duties, we're also expected to support other programs during public health emergencies, like communicable disease outbreaks that include Mpox clinics and measles response. This often means being pulled away from our primary role where staffing is already inadequate. A colleague who also intended to speak today here was unable to because of severe staffing shortages in their program. Their staff are already working overtime just to maintain basic coverage, and they chose not to come today so they didn't further burden their coworkers or risk service delivery. Many programs are now facing longer wait lists or have had to suspend services altogether due to the inability to maintain a full complement of trained staff. For example, the North York Sexual Health Clinic has been closed since COVID, and because there's not enough trained staff to reopen. As a result, many staff struggle to find STI services for clients in those regions, and some clients have had to resort to going to the eMERGE department. In the 2025 Toronto Public Health Risk Management Report, the highest identified risk was talent availability. The report cites staff fatigue and departures for other opportunities as key concerns. What it fails to acknowledge is that many of those departures are for significantly better wages and a more manageable workload doing the same job at another health unit. Many staff cannot afford to live in Toronto, so why would PHNs choose to remain at TPH when they live outside Toronto, they have to commute, and they get paid 10 to 22% less? For those of us who do live in Toronto, like my colleague, are forced to take second jobs to make ends meet. To be clear, we are currently the third lowest paid public health nurses in Ontario, and I'm sure after those contracts are negotiated, we will once again be the lowest paid public health nurses in Ontario, which makes us the lowest paid public health nurses in Canada. So, public health nurses and also our other health professionals are asking the Board of Health allocate funds in the upcoming budget to address these wage inequities and ensure competitive compensation. Thank you for your time.
Thank you. Any questions for the deputant? Councillor Chang, go ahead.
So I thank you for your deputation. You mentioned that after these negotiations are done, are there negotiations currently happening?
Yeah, so there's two health units that are behind us that are either at the end of their contract or they are negotiating right now.
Ah, I see.
Yeah, so I'm sure once they've been adjusted. So if you look at the stats from January, there's a few public health units that dollar value has changed because they've recently ratified their contracts, yes.
I am concerned to hear about the closure of the North York Sexual Health Clinic. And I'm wondering how many clients were previously served through that clinic? Do you know?
I don't know off the top of my head. We were open 3 days a week, and we also had additional prep program that we were providing at that office. I can tell you how often we were open, and we were probably seeing, so 3 days a week, at least minimum 75 clients a week just on our regular week. Yeah.
And how many of similar type programs have been paused or stopped because of the issues that you raised?
So based on the information provided by the public health nurses, so you would have to confirm this with management. I know that in the productive early years team, they're just up to 7 staff now being fully trained when they have a full complement of 13, and that's on the Crossways team specifically. I know that our school liaison team, only high-risk nurses have an assigned nurse, while the other approximately half have to request services. And, keep in mind, all of these programs are being pulled if needed for outbreak response. I know in our program, we've had to reduce the follow-up that we do for communicable diseases. So in trying to manage case workload, or even we highly depend on community services to assist with our HIV clients. And I don't know if you read in the news Friday that they are actually closing. So that's another loss of service that helps us with our work and decreases the amount of work we're doing specifically ourselves.
It was alarming to hear that in Toronto we have a 1 to 7,300 ratio, whereas I think you mentioned Newmarket is 1 to 5,500.
Yeah, York and Halton. I apologize, I wasn't able to get other numbers for you today.
Right. And so this is not something that happened overnight. I'm guessing this kind of, capacity limit has existed for a few years now. And what would be the impact of such a drastic difference in the amount of public health nurses available to serve our growing city?
You mean what could happen if we had additional nurses, or what have we
Sure,
lost?
I guess that would be a proactive way to, or what are the gaps, or what are the
I think management would probably have a better idea in terms of what they need resources for. But all of the resources we have, we would have more people to provide those same resources, and we could reduce the wait lists. I know one of the program has, I think, last 900 people on a wait list. So if we had those additional nurses, we could be providing those programs, right?
So what is that program that has a 900-person wait list?
Investing in families. Sorry, do you want to sit with me, Arlene?
Okay.
Yeah.
Thank you for your answers. I really appreciate it.
You're welcome.
Okay, thank you. Any other questions from the deputies? Seeing none. Thank you so much.
Thank you.
Mary Rutka?